Okay, welcome once again to the 9th Health Exhibition in Congress and the hybrid session organized by Ethiopian Society of Internal Medicine and Yetena Weg. Our second presentation for today would be with Dr. Solomie Ayalew, consultant neurologist from Tukur Anbessa Specialized Hospital, Addis Ababa University. Today we'll be seeing updates on diagnosis and management of peripheral neuropathy. And for our online audiences, I would like to remind you that if you have questions, you can post them on question and answer segment on Zoom, and we'll address them at the end of the presentation, and we'll have post-CME quizzes for certification purposes, so stay with us, and we'll proceed with Dr. Solomie.
Good morning, everyone. I will be presenting on updates on the diagnosis and management of peripheral neuropathy. So my presentation will include some introductory remarks. Brief anatomy and physiology on the types of fibers and the function of fibers, the prevalence and impact of peripheral neuropathy on quality of life, the types and the cause of peripheral neuropathy, and some clinical signs and symptoms that we commonly see, and advances in diagnostic approach. And I'll be selecting, I will be selecting a few clinically relevant and commonly presenting peripheral neuropathies for further detail. So as you well know, the peripheral nervous system refers to part of the nervous system outside the brain and the spinal cord. It includes the cranial nerves, the spinal nerves, their roots, branch, and the peripheral nerves together with the neuromuscular junction. So although the anterior horn cells are the part of the central nervous system, they're usually discussed with the peripheral nervous system because they're part of the motor unit. So the PNS includes it's like a cable or nerve fiber or axons that conduct information to and from the central nervous system. So the PNS is divided into the somatic part and the autonomic nervous system. The somatic part controls the sensory and the motor parts, and the autonomic nervous system, it includes the sympathetic and the parasympathetic nervous system, which serve the function of innervating the involuntary muscles of the heart, the GI system, the genitourinary system, the glands in the body. So briefly on the anatomy of the neuron, and so this is a neuron. We have a cell body. These are the dendrites. This is the axon, and this is the axon terminal. So for large myelinated fibers, the axon will be covered by myelin sheath, which allows a fast saltatory conduction of action potential. So this is a neuron. And this figure shows the connection of the spinal cord with the peripheral nerve and the muscle. From the anterior horn or the ventral root, we have, starting from the anterior horn cells, the motor neuron starts, and following that, it has the axon covered by myelin sheath, usually for motor nerves, and then it goes and innervates the muscle through the neuromuscular junction. On the other hand, the sensory nerve collects whatever information is in the periphery, pain, temperature, touch, vibration, proprioception, and transmits that information through the axon to its cell body, the dorsal root, which is outside the central nervous system, and through the dorsal root ganglia goes to the posterior horn. So peripheral neuropathies, they are common neurologic problems. They are caused by dysfunction of the peripheral nerve. Either you find dysfunction of the motor, the sensory, or the autonomic functions. There are a myriad causes of peripheral neuropathy, commonly entrapment, systemic diseases, inflammatory, autoimmune, paraneoplastic, ischemic conditions, deficiency states, toxins, infections, so lots of causes. So as such, we need a logical and a systematic approach to narrow down our diagnosis and get to the treatment. So we need a detailed history, a detailed physical examination, if possible, detailed electrophysiological exams, with or without ancillary tests to reach to our diagnosis. So a few remarks on the size of fibers and so we have myelinated somatic and myelinated autonomic fibers, and then we have the unmyelinated somatic and autonomic fibers. So basically there are lots of classifications of these fibers, but clinically relevant here is the size of the fibers. The small unmyelinated fibers and the myelinated fibers are not usually tested on routine electrodiagnostic tests. So whenever we have a small fiber neuropathy, ordering a non-nerve conduction study or EMG will not be relevant here. But for larger fibers, we have the A beta and the A alpha. We can order those tests because we can actually assess the nerves on the nerve conduction study. So this was the point I wanted to make. So prevalence and impact, about 10% of adults have neuropathy. It accounts for about 10% of all visits to our clinic, to the neurologic clinic each year. So up to 50% of patients will have pain because of polyneuropathy, and this can be very disabling and excruciating, and it's very expensive. The US alone spends like $11 billion per year treating the complications of diabetic polyneuropathy. And this is only expected to rise with the incidence of diabetes, which is also increasing in our country. Some studies in our country show that diabetic neuropathy in type 2 patients ranges from 14 to 20%, which I think is a bit of an underestimation. And the main reasons for electrodiagnostic referrals in Black Line, they did a study, was polyneuropathy, which was in this case inflammatory polyneuropathy, mainly Guillain-Barré syndrome. The second was carpal tunnel syndrome, and the third was radiculopathy. So the impact is pain is often disabling for these patients. It increases morbidity, mortality, and quality of life in general. Decreased sensation, weakness of extremities, predisposes patients to difficulties in walking. Patients with polyneuropathy are 4 times more likely to undergo amputations. And pain, it interferes with sleep, with quality of life, and it may even lead to depression. And when they ranked diabetic neuropathy in 2019, they ranked it as the 8th and the 9th leading cause of disability in the US, actually. So a great impact. But still, a third of physicians, less than a third of physicians will recognize this polyneuropathy. And this lack of understanding of the true burden of the condition actually delays diagnosis and leads patients to suffering and complications. So there are specific injuries. The neuron responds to injuries in a specific manner. Although there are many causes of neuropathy, the neuron, it responds in a specific manner. So when we come to Wallerian degeneration, it is when the injury is so severe, it causes axonal degeneration and also myelin interruption. So it can be due to contraction, laceration, chemical injuries, ischemia. Axonal degeneration is the most common cause of the most common response to injury. So this happens in metabolic, toxic, and sometimes inflammatory polyneuropathies. A primary neuronal degeneration is when the dorsal root ganglia is affected. The whole, the soma dies, the sensory neuron dies, and so there will be degeneration of the whole axon and the myelin. This is classically seen in Tebes dorsalis. There will be a degeneration of the dorsal root ganglia and the dorsal column, which causes a severe sensory ataxia and lancinating pain, and various other things like a gastric crisis with bladder abnormalities and the pupillary abnormalities. So segmental demyelination usually occurs in inflammatory or in inherited polyneuropathies. So the types of peripheral neuropathies, the first is mononeuropathy. That means it affects a single nerve. Usually it's a focal process, like a direct trauma, compression, entrapment, etc. Multiple mononeuropathies is when there are multiple, well, from the name, we have focal neuropathies which occur in non-contiguous areas. For example, you have neuropathy in the upper arm and then neuropathy in the lower extremity. So if you have multiple mononeuropathies, then it's multiple mononeuropathy. Polyneuropathy is rather it's a symmetrical distal motor and sensory affection. That means usually the legs are involved before the hands are involved, or vice versa. Small fiber neuropathy, they affect the small fibers, and they are usually the painful neuropathies. So there are many diagnostic clues in the history and the physical examination that we can gather before we go into electrodiagnostic tests and sophisticated tests before to make our diagnosis. So again, there will be derangement of the motor, sensory, and autonomic functions. So negative motor symptoms, the patient will have weakness, atrophy, and walking difficulties. Positive symptoms, on the other hand, cramps, fasciculation, tremor, or myokymia, which is a rare undulating movement of the muscle that we can see. It's a positive motor symptom. Positive sensory symptoms are basically pain, different types of pain. Prickling, searing, burning, tight band-like sensations. Paresthesia occurs or is reported when a patient has spontaneous, there's no stimulus, but the patient feels discomfort or unpleasant sensation. Allodynia is when the non-noxious stimulus is felt as pain, and hyperalgesia is when the patient is oversensitive or hypersensitive to pain. So the extreme form of positive symptoms are neuropathic pain. It's often deep, burning, drawing. Patients describe it as jabbing, shooting pain, and it's usually increased at night. It is classically increased at night and during periods of rest. So negative sensory symptoms is when there's loss of function. So there's loss of pain sensation, temperature sensation, and there's loss of vibration and proprioception, which usually manifests as imbalance or gait problems. Symptoms of autonomic dysfunction, they can be helpful because they are they have a predilection for particular types of polyneuropathies. Orthostatic intolerance, you have excessive or reduced sweating, bowel bladder dysfunction, and gastroparesis with diarrhea or constipation can occur. So again, historical information about the onset, the duration, and the evolution of symptom is important. Whether it is acute, subacute, chronic, whether it is monophasic, progressive, or relapsing. For example, acutely, classically, you have GBS, Guillain-Barré syndrome, you have acute porphyria, you have toxic polyneuropathies. In chronic indolent course, usually inherited polyneuropathies. Subacute to chronic, we have some inflammatory neuropathies like CIDP, chronic inflammatory demyelinating polyradiculoneuropathy, which we will discuss briefly. So again, the distribution, if it's a mononeuropathy, then it's a local process. If it's polyneuropathy, then it's probably a systemic process. Like diabetes, other like renal or liver things, toxic, deficiency states, or even drugs, chemotherapeutic agents, etc. So motor deficits usually dominate in certain types of polyneuropathies, like in acute and chronic inflammatory demyelinating polyneuropathies, in hereditary neuropathies, and in neuropathies associated with certain types of multiple myeloma, and in intoxication, in organic phosphate intoxication. So autonomic dysfunction, it's not the sole manifestation, but it can be found in GBS, and in chronic neuropathies, diabetes is a major issue. So always when we ask about the history, we have to have the review of systems, because systemic illnesses, I said drugs, various other things like deficiency states, other things can actually explain our neuropathy. So physical examination, palpation can be used, although it is unreliable in some cases, like in leprosy, in inherited like Charcot-Marie tooth, you can find some thickened hypertrophied nerve trunks, and also in neurofibromas, schwannomas, etc. there are some things on the skin and on its appendages that we can see that can help the examiner narrow down the diagnosis. These are really, really rare things. Intoxication with thallium and arsenic, for example, it can show up on the hair, alopecia, and on the nails. And what I want you to remember from this slide is pace cavus and Hamertos from CMT, because CMT is an inherited polyneuropathy, which is fairly common, actually, probably under-recognized in our setup. The other thing that we need to remember is electrodiagnostics tests will almost always help us in confirming the presence of neuropathy, in localizing where the neuropathy is, and in telling us is it demyelinating, axonal, or is it mixed, and in helping us in the diagnosis. This test, the quantitative sensory test, the skin biopsy, etc., usually for small fiber neuropathies. In general, nerve biopsy only recommended for vasculitis or amyloid or leprosy. Sometimes maybe CIDP. I have never seen nerve biopsy done. It's just a theoretical concept for me. Laboratory routine tests have to be done. CBC, ESR, CRP, renal functions, fasting blood sugar, thyroid studies, B12 levels, and CSF analysis. Serum autoantibodies, they can be helpful in some cases, but I think these are just theoretical at this point. Even then, even with all these investigations, 30% of polyneuropathies, we cannot diagnose the cause. But fortunately for us, these cryptogenic sensory polyneuropathies, they do have a good prognosis, and they don't usually cause disability. So a very common mononeuropathy is carpal tunnel syndrome. Probably have seen it. Everybody has seen this at some point. It's the most common entrapment neuropathy. It's because the median nerve, as it passes through the carpal tunnel, together with the long flexor, finger flexor tendons, is bound to have some sort of injury because it's bound posteriorly by the unyielding, very strong transverse carpal ligament. So usually it's bilateral and dominates on the dominant hand. So this is a very severe case of carpal tunnel. This, you can see there is atrophy of the abductor pollicis brevis on this side, slightly on this side as well. We don't want this to happen. We want this we want to prevent this from happening. So patients will come to us, I have like nocturnal pain, paresthesia, it wakes me up from sleep. So sometimes the entire hand is involved. Even sometimes there can be referred pain to the arm and even to the point of the shoulder. So sensory changes on the distribution of the median nerve, the thumb, the index, and the middle finger. There will be some sort of sensory deficit we can objectively examine for. Provocative tests, we can do Fallon test, which is very specific for carpal tunnel. You make the patient bend the wrist at 90 degrees for about a minute, and there will be reproduction of the paresthesia. The patient will complain, oh, I have pain in my finger. So it's about 80% specific. So there are conditions that predispose patients to have CTS. Pregnancy is one of them, diabetes, obesity, older age, rheumatic arthritis, gout, etc., etc. So it's very common in diabetics. If you have carpal tunnel, if you do fasting blood sugar, you will find in 10% of the patients diabetes. So if your diabetic patient comes, I have hand pain, think of CTS. Electrodiagnostic tests, very useful, diagnostic in 70% of cases. Treatment in mild cases, we do splints in the neutral position, and we give them non-steroidal. Sometimes we give them oral steroids, but it's not very practical because we can't give it for a long time, but they work. The other is local steroid injection. We inject steroid into the carpal tunnel. It helps if patients fail for the conservative management. Surgery is useful for patients who have moderate carpal tunnel syndrome. That means not too mild or not so severe that they won't benefit from the surgery. Another entrapment is ulnar neuropathy. second most common entrapment usually occurs because of some sort of compression that happens on the elbow, or because we're like putting our elbow on the table or on a hard surface. Diabetes is also a predisposing factor. Usually patients with severe ulnar neuropathy, they come with clawing of hand or the benediction sign. They will have pain and paresthesia on the ring and the small finger. Again, electrodiagnostic test is useful, especially for distinguishing with more proximal lesions. Conservative management should be instituted at least for 3 months before we go to surgery, because surgery has its own problems. Elbow protectors and avoiding any inciting activities, if it is occupational or not, will be very useful for this. Common peroneal nerve, again, common problem in the lower extremity, usually comes with foot drop. The patient, they keep on tripping, or they keep on trying to clear the stairs. They trip because they cannot elevate the toe of the foot. And they have some sensory symptoms on the lateral side of the leg and also the dorsum of the foot. Usually has good prognosis. This can happen in improperly put casts, for example, in critically ill patients if there's compression and habitual leg crossing like that. That can cause peripheral neuropathy, peroneal neuropathy. Multiple mononeuropathies, I don't want to dwell on that because we don't have time, but diabetes can cause multiple mononeuropathy, especially the axonal type. HIV can cause, and also the classic example is Hansen's disease. In demyelinating, these are all very rare entities, and I will not be dwelling on those. Hereditary neuropathies, they are a heterogeneous group of disorders. They have a very insidious and indolent course. It takes years and years to have any symptoms, and nearly about 40% of the patients which are sent for diagnosis end up having chronic polyneuropathies. Detailed family history is important because because of inheritance and skeletal abnormalities like hammer toe, high arched pes cavus, scoliosis. Negative family history does not exclude, because these entities can also occur in de novo mutations. The most common is CMT, the Charcot-Marie-Tooth disease, up to 40 per 100,000, which is common. And there are two types based on the electrodiagnostic findings, the demyelinating form and the axonal form. Patients usually have weakness and muscle wasting, especially on the leg. The peroneus longus and the tibialis anterior will be involved. Sensory involvement might be there, especially if we elicit like a careful physical examination. Deep tendon reflex is usually depressed. So you can see on the leg, this is a thin leg, right? There's atrophy of the tibialis anterior and the peroneus longus. And this is a high arched foot. Because of the weakness of the intrinsic muscles of the foot, the foot, I suppose it just adapts and has a high arch. There's also thickening of some of the peripheral nerves. This is a great auricular nerve, which is actually visible, which is not supposed to be visible. So there are like lots of CMT mutations. So I just want you to remember there are autosomal dominant, recessive, and X-linked variants. Treatment is it's very slow. The disability occurs later in life, and lifespan is normal, mainly symptomatic. If they have foot drop, if they have a pes cavus, just advise on footwear and broad-fitting shoes, ankle braces, orthopedic procedures for severe foot drop. That one thing we need to remember is these patients should avoid neurotoxic drugs because of the underlying polyneuropathy, they are very susceptible to having additional neural damage. The inflammatory demyelinating polyradiculoneuropathies, we have the GBS and the CIDP. So GBS, I'm sure everybody is familiar with GBS. It was described 100 years ago, manifested by weakness, areflexia, very minor paresthesia with albuminocytological dissociation, which is the protein is disproportionately increased as compared to the cell. The cell is usually less than 10, but the protein is like 100. When you do a CSF analysis. We would need to admit some of our GBS patients in the ICU because up to 30% of patients will need ventilatory support. But in their setup in the Western, they used to have a mortality rate of 33%, which has decreased to about 1% because of all the supportive care and the ventilatory support. But still, in our setup, there's a high mortality associated with GBS. Pathogenesis is it is immune mediated. There is a synergistic interaction between the cell mediated and the humoral immune responses against some peripheral nerve antigens. It's not fully elucidated, but that's what the theory is. So patients, in 2/3 of the cases, we have a preceding event, some sort of event that will trigger the autoimmune reaction. So an upper respiratory or a GI infection, surgery, or immunization will be found maybe 1 to 4 weeks before the onset of the neurological symptoms. So there are no such responsible agent that's been identified except C. jejuni. Campylobacter jejuni is a bacteria that's been identified in GBS patients in China, actually. In China, it occurs as an epidemic after gastroenteritis caused by C. jejuni. But there are some viral infections which are linked to GBS, CMV, EBV, VZV, hepatitis virus, HIV, mycoplasma, and hemophilus are associated. So classically, they present with ascending type of weakness. It starts from the legs and goes up and involves the arms and the face and then the oropharyngeal muscles. Paresthesia is very mild. They do complain. I have some tingling on my fingertips or my toes, but it's not a very prominent symptom. Severe cases, they will involve the respiratory muscles. They will need ventilatory support. Less often, they can come with descending infection, descending pattern. They can involve the face, the arm, and then goes down. The severity, it can range from the patient is coming to you walking or is just limping a little bit, or on the other spectrum, the patient is quadriplegic and can't breathe. So different manifestations. Hyporeflexia or areflexia is always present. It has to be present. I mean, unless it is very, very early, it's almost always present. Cranial nerve involvement, that means facial weakness, is present in 75%. Facial and oropharyngeal. Facial paralysis, 50%. 30% would need ventilatory support. Autonomic dysfunction in up to 65% of patients. It occurs between the 2nd and the 4th week of illness. There are lots of autonomic dysfunctions, hypotension, urinary, GI, hypertension, arrhythmias, different types of arrhythmias, which can actually kill patients. These are called vagal spells. When there is excessive vagal activity, the patient will have bradycardia or asystole or heart block. And this can happen spontaneously on when you're just doing a tracheal suctioning. So we have to be aware of that. We have to monitor these patients. Especially severe cardiac arrhythmias with hemodynamic instability, it's usually found in quadriparetic patients who would require respiratory failure. The common types, the subtypes are the inflammatory demyelinating polyneuropathy, the acute motor axonal neuropathy, and the acute motor sensory axonal neuropathies. Rare variants, you have Miller-Fisher syndrome and other variants. So this is what I found in the literature in Ethiopia. The numbers are comparable. Like 60% of them will have some sort of preceding event, like respiratory tract infection, diarrhea, or vaccination. Majority of them, 80%, ascending quadriparesis, 12% descending quadriparesis. So diagnostic tests, CSF analysis, very important. But keep in mind that in the first week, CSF analysis may be normal in 50% of patients. And in the up to 10% of cases, they will have a normal CSF finding throughout the illness. But CSF examination is still very important. Serial electrodiagnostic studies are critical. In electrodiagnostic, in the usage of electrodiagnostic modalities, we use that to exclude other causes, botulism, myasthenia gravis, etc. And they're not awfully specific, especially in the first 2 weeks of illness, but they can have some non-specific findings which may help us, which is why we should do, if possible, serial electrodiagnostic tests. So the diagnostic tests become more specific for axonal or for demyelinating features after 2 weeks, unfortunately. So we have to keep that in mind. Treatment is general supportive management. Patients, we have to triage patients which will require ICU care. So patients who have rapid disease progression, they come to you like, oh, yesterday I had difficulty walking. Today I can't sit up. So this is a very rapidly progressive disease. So admission within less than 7 days of onset. Severe limb weakness, presence of facial weakness and bulbar weakness is another alarming sign. Dysautonomia and signs of respiratory insufficiency. They should be admitted to the ICU for closer observation. So in the treatment of GBS, our best chance of favorable outcome would be treating the respiratory failure and the autonomic dysfunction. So once these things are treated and other basic supportive care are there, the patients will survive. Cardiac monitoring, I've said about the autonomic dysfunction. Pain should be treated as well. Nutritional, general supportive care like preventing DVT, PE, pulmonary embolism, and prompt treatment of nosocomial infections is mandatory. Instituting early physical interest physiotherapy, preventing pressure sores, bladder bowel care, and exposure keratitis is the routine practice. Specific therapies, we have IV immunoglobulin or plasma exchange. IV immunoglobulin is usually what we use in our setup because of the ease of use and also availability. But it doesn't reverse weakness. What it does is it actually accelerates recovery. So one of the factors that that is a good favorable factor for recovery is actually whether or not they had received immunomodulatory treatment. CIDP is like GBS because most of the pathogenesis, they overlap with GBS. They don't have a reflex. They don't have reflex. They have weakness, and but it's different because of the course of the illness. You have to be sick for at least 2 months before saying this is CIDP, and fortunately, CIDP is responsive to steroids. Another overlap is actually, if you do CSF analysis, you will find the same findings as GBS. They will have albuminocytological dissociation. So patterns in the older and in the majority of patients, continuous stepwise progression over months and years can happen. In the younger patients, relapses with partial complete recovery can happen. Very rarely you see they present with GBS-like symptom, but then they end up being CIDP because they progress over the period of 2 months. Prevalence is rare. It's 1 to 2 per 100,000, similar as GBS. So weakness must be present for at least 2 months to say CIDP. Usually weakness is symmetrical. Distal and proximal muscles are affected equally. Motor sensory involvement is there. Areflexia is there. And stocking glove distribution of numbness may be there. There are several variants which are there. Investigation is NSAID-EMG can be diagnostic of this Syndrome, CSF analysis, mandatory to distinguish from other causes of polyneuropathy, chronic subacute polyneuropathy. Treatment, we have three modalities, IVIG, steroid, plasma exchange. They are all equally efficacious, but IVIG, they usually use IVIG because of the ease of use and also because you just have to give it 2 or 3 times and then they usually go into remission. Steroids, you might need to give it for a long time, and considering the side effects of steroids, I think we have to consider those things. But they usually respond very nicely to steroids. Up to 70% of them, we end up tapering the steroid dose to very small doses. Plasma exchange is also an option, but the schedule is not known, and it's financially and technically difficult. Diabetic neuropathies, the most common cause of neuropathy in the world. It's a generic term, diabetic neuropathies, to describe signs and symptoms of peripheral nerve dysfunction in patients who are diabetic after we have excluded all other causes of neuropathy. So the American Diabetic Association recommends that we screen patients for peripheral neuropathy when we diagnose type 2 patients at the time of diagnosis, and in type 1 patients 5 years thereafter, and then annually. I cannot overemphasize the fact that we should exclude other causes because diabetes is common and diabetic polyneuropathy is common as well. It may coincide with other conditions like CIDP in B12 deficiency, alcohol neuropathy, and these things are treatable and their prognosis is quite different from diabetic neuropathy. So to monitor or to screen patients, we check the 3 functions. The small fiber function is pinprick and temperature sensation on the sole of the foot. Large fibers, we do reflex, we do vibration and proprioception. And they also do 10-gram monofilament, which they use a filament to just jab at the foot. And the filament kind of bends, and if the patient feels it or not, it has its own limitations, but it's routinely used in clinical practice. I've never seen it personally, but they use it. But I think it's enough to do the pinprick and the temperature sensation. You check the reflex and the vibration sensation. This is very good. So the most common form of diabetic neuropathy is the distal symmetrical polyneuropathy. It's so common that physicians and other colleagues, they think that diabetic neuropathy is equal to distal symmetric polyneuropathy, but it's actually not. But it's very common. Sensory deficits predominate, usually minor motor symptoms. They have stocking glove pattern of sensory loss. First the toes, the knees are involved. Once the sensory loss passes the knees, then it involves the fingers and the hand, and then in very severe cases, the trunk. There are large fiber variants and small fiber variants. So I just put this table to show you that there are generalized and focal and combination of neuropathies in diabetic neuropathy. In distal symmetrical polyneuropathy, the large fiber variant, the patient will have painless paresthesia at the beginning, at the foot and the toes. And when you check the vibration and the joint sensation, then this is impaired. They will have diminished stretch reflexes and they will have sensory ataxia. That means when they're walking, there will be some sort of ataxia. You can check sensory ataxia by doing Romberg test. Romberg test is you stand them up and you ask them to close their hand and put their feet together. If they start to sway and lose their balance, they have sensory ataxia. That means they need the visual input to actually maintain their balance. So whatever they're getting through their muscles, the vibration proprioception is actually impaired. So this implies a large fiber neuropathy. Usually it's asymptomatic, and these patients, they tend to get foot ulcers because they can't feel their foot and their toes. The other subtype is the painful one, the small fiber variant, deep burning, stinging character. They can have allodynia, pain temperature sensations are impaired. with relative preservation of vibration in joint. Muscle stretch reflexes may or may not be involved, and they're usually associated with autonomic neuropathy. So other things I think we might see are impaired glucose tolerance neuropathy. It's when a patient with impaired fasting blood glucose comes to you with burning and paresthesia on the foot. It's usually treatable once the impaired glucose is corrected. It usually goes away within a few weeks. Treatment-induced neuropathy is an acute painful neuropathy that happens when you start insulin therapy in the patient. Again, very painful, but after some time, after a few months, it will disappear. A rare form of diabetic neuropathy is diabetic neuropathic cachexia. Usually happens in men, causes severe weight loss, depression, insomnia, and impotence. The other commonly seen problem is autonomic neuropathy in diabetes. Usually correlates with somatic neuropathy. That means if they have very severe distal symmetrical polyneuropathy, they will have autonomic neuropathy. It can be subclinical to severe, involve the cardiovascular, the GI, the genitourinary system. Diabetic cardiac autonomic neuropathy usually comes with resting tachycardia, loss of sinus tachycardia, and orthostatic hypotension. GI motility abnormalities, gastroparesis, diarrhea, constipation can occur. Another problematic thing is unawareness of hypoglycemia because they have inadequate sympathetic and adrenal response to the hypoglycemia. They don't know that they are hypoglycemic. Bladder atony and especially impotence, as you well know, is very, very common. Another thing that you might take from this lecture is the diabetic lumbosacral radiculoplexopathy. It's a particular type of plexopathy that happens. It's restricted to the lower limbs. It happens in type 2 diabetes, usually older than 50 years, and usually unilateral severe hip pain and anterior thigh pain. And then they come to you, I can't walk, I can't get up from the chair, I can't climb stairs. It's usually asymmetrical, and you will see there will be wasting of the pelvic-femoral muscles, either abruptly or in a step-wise progression. There will be weight loss, and there is an overlap with the distal symmetrical polyneuropathy. Recovery is usually very slow and incomplete, and it can take up to 2 years for them to recover. Some patients might respond to IV immunoglobulin for these patients. So treatment-wise, so specific therapy to actually decelerate, no, to reverse rather, the nerve damage is currently not available. What we can do is practice good glycemic management. So good glycemic management, it can prevent diabetic peripheral neuropathy in type 1 patients. It can somehow modestly slow the progression in type 2 patients. In type 2 patients, treating other modifiable risk factors like lipid-lowering agents, blood pressure control can actually aid in the prevention of polyneuropathy progression. The other thing is, of course, we can't fix the cause or we can't reverse the cause, but we can treat the pain. We treat them with anticonvulsants like pregabalin, gabapentin, carbamazepine, tricyclic antidepressants are very good. Albeit they do have side effects, but most patients tolerate them. And duloxetine is a newly approved drug, which unfortunately is not available in our setup. But we do have TCS, we have tricyclic antidepressants and anticonvulsants. Simple practical advice that we can give to our patients. The patient has gastroparesis, eat small frequent meals. Use maybe metoclopramide. For orthostatic hypotension, adequate hydration and salt ingestion. Sometimes fluorocortisol can be given. In patients who have genitourinary problems, collaborate with the urologist. If there's neurogenic bladder, then frequent voiding, because these patients, they don't feel the urge to void, so their bladder is atonic. It can carry lots of volume of urine. So frequent voiding and sometimes self-catheterization may be required. Oral treatment for impotence with sildenafil and other similar drugs can be tried. Other things, we can practice proper foot care, skin care to avoid foot ulcers. Can be seen. The other thing is, I just wanted to mention some things about alcoholic and nutritional deficiency neuropathies. Alcoholic neuropathy is also very commonly seen in general practice. Up to 50% of patients who are chronic alcoholics will have polyneuropathy. The cause is, alcohol is neurotoxic by itself, but also nutritional deficiency, especially thiamine deficiency, it's tied up with that. Clinically, insidious and progressive, it progresses slow. Motor involvement comes from distal and then proximal. It actually looks like diabetic polyneuropathy. Sensory involvement, it involves all modalities. Deep tendon reflex may be lost. They will have sensory ataxia, and it may be coupled with cerebellar ataxia, and autonomic dysfunction may be seen in very severe cases. Electrodiagnostics test shows you sensory motor axonal polyneuropathy, which is a bit different from diabetic neuropathy. So treatment is abstinence from alcohol and addiction counseling, nutritionally balanced diet, and usually has a good prognosis. Of course, we have to treat the pain as well. For mild to moderate polyneuropathy, if they abstain from alcohol, good prognosis within 3 to 5 years. Nutritional deficiency, it's already mentioned with regards to megaloblastic anemia. B12 deficiency necessary for B12 necessary for DNA synthesis. Usually, it can be very low in elderly patients. We don't know why. In HIV patients, in patients who have risk factors with gastric terminal ileal resection, and in other malabsorption syndromes. It takes several years for cobalamin deficiency to cause a problem, because we have adequate stores in the body. The patients present with macrocytic anemia, atrophic glossitis, peripheral neuropathy with optic atrophy, and subacute combined degeneration, which is the posterior column of the spinal cord is affected. They will have absent ankle reflex with spasticity, and they will have weakness, so just spinal cord lesions, and they will have sensory level. Usually affects the thoracic rather, sometimes the cervical. It can manifest without the anemia, unfortunately. So keeping that in mind, because this is a treatable cause. Usually loss of vibration proprioception sensation, posterior column damage, hyperreflexia on the other limbs, but absent ankle reflexes. Sensory ataxia with some sort of sensory level can be seen. Treatment has already been mentioned. Cobalamin injections, and depending on the underlying cause, we may need to continue. Recovery depends on the duration of the illness. If it's been around for maybe 4 years, then the patient may not recover at all. And the severity of the symptoms at baseline and presence of anemia. Small fiber neuropathy, just a few things to mention. We can't see them on electrodiagnostic tests. Usually overlap with autonomic neuropathies, and can happen in diabetes mellitus and impaired glucose tolerance, amyloid neuropathy, HIV neuropathy, and the rest are really rare entities. And so this is the presentation.
Okay, thank you, Dr. Solomie, for the wonderful summary of this broad topic. For the sake of time, we'll post the questions for our online audiences, and meanwhile, we'll be accepting questions from our in-person audiences. Then after, we'll proceed to questions that were forwarded from Zoom attendees. So any questions from in-person audiences? Okay.
Okay, thank you. Actually, I don't have questions, so I want to give some comments on some practical issues regarding the vitamin B12 deficiencies and peripheral neuropathy, especially in patients with diabetes. So we have seen that some reports of chronic metformin use, even though metformin is a very outstanding drug and still the first line drug in the fight against type 2 diabetes. So we see some reports associating with vitamin B12 deficiencies. So in that group of patients where the metformin use was prolonged and long-standing use, so this is important to consider vitamin B12 deficiencies and make sure that these patients are on adequate daily supplements. And usually the cause of peripheral neuropathy could be also ascribed to the chronic vitamin B12 deficiency. So it's important to see that. And the other issue is what we found is in peripheral neuropathy, usually the vitamin supplements in the over-the-counter supplement of vitamin supplements, we see some OTC vitamins containing pyridoxine up to the level of 150 to 100 sometimes milligram. So there are few reports of pyridoxine toxicity, and what will be your reflection on that and the over-the-counter use of vitamin supplements? Is it really worth to see the contents or the like? Maybe some reflection on that. Thank you.
I take your point about metformin. It's a very good point. We have to screen patients, especially who are on chronic metformin therapy. We have to do their serum level at some point. And again, as I've said, diabetic neuropathy, it's not, we don't have to attribute everything to diabetes. We have to investigate other causes and treat those causes. Pyridoxine, prolonged levels of pyridoxine, like more than 150, 200, sometimes 300 for prolonged periods can cause neuropathy. On the other hand, pyridoxine deficiency can cause neuropathy, especially in the context of when patients take anti-TB, INH, which lowers the level of pyridoxine in the body, and I think it replaces pyridoxine. So we have to be careful about this over-the-counter medications. I have not seen preparations above 150, but I've seen 100, I've seen 50. Fortunately for us, we don't have like 200. So avoid those things. I mean, if you give, be reasonable. I mean, for example, if the patient is on anti-TB, then he has to receive for the entirety of the course, not just for the 2 months, for example. So yes, that's a very good point. So over intoxication or deficiency state in pyridoxine, B6 is actually interesting. It causes neuropathy in both spectrums.
How about the multivitamin preparations that are prescribed over the counter from several clinics for patients complaining of peripheral neuropathies?
So again, peripheral neuropathy is such a broad term. It's just like putting a bandage on. It's just a temporizing measure for me. If you ask me, what are you treating? You have to know the cause of the neuropathy before treating the neuropathy. So multivitamin, again, you have to know the content of the neuropathy. If there is any deficiency state, maybe that may be helpful, but just giving them multivitamin is it's just a placebo for me, if you ask me.
Okay, thank you. Any other questions from our in-person audiences?
Thank you, Dr. Solomie, for a nice presentation. I want to ask about carpal tunnel syndrome during the time of pregnancy. What is the incidence and also treatment-wise, and also its possibility of response post-delivery. I want to ask about that.
Okay, so I don't actually know the number of the incidence of CTS in pregnancy, but I know it's a predisposing factor. And we see a lot of pregnant ladies coming to us. I have tingling, I have paresthesia during the night. Treatment is like any other treatment. If it is mild, then we do splints. We don't give non-steroidal during pregnancy. We try to avoid during pregnancy. If it is a very mild CTS, for example, I've observed that after pregnancy, after they lose the weight, it usually just goes away by itself. If it is a moderate one, if it's moderate to severe, then maybe do steroid first. And if that doesn't work, then you have to do surgery.
Thank you for your excellent presentation. On the follow-up question from the previous one, how do you see the effect of oral steroid on carpal tunnel syndrome? And how do you administer the durations, tapering? And my second question is on CIDP. As you said, we need close to 4 weeks of duration for consideration of CIDP. And in patient with 2 months, yeah. And in patient who we have suspected of CIDP, do we just give them the steroid at the time of their presentation, or do we look for, wait for the whole 2 months?
So with regards to the steroid administration for carpal tunnel, usually I give them short course, 5 days, 7 days, because beyond that, I mean, they work, they really work, but beyond that, then you're gonna have to worry about the side effects of steroids. So if I give them that, if the pain doesn't go away, I usually go for local steroid injection. That is a very good a way of sort of decompressing the carpal tunnel. You inject like 1 ml, 40 milligram of methylprednisolone with local anesthesia. You inject it into the carpal tunnel. They usually don't have any symptoms for 6 months and above. So local steroid is much better than systemic steroid. With regards to CIDP, do I wait for 2 months to make sure if the patient is CIDP or not? I don't think so. I don't think so, because for us to consider CIDP, the patient comes to us. It's usually like a very slow progressive illness. So the patient may come to you like after 3 months, after 6 months. But if the patient comes to you like after a week, I have like weakness of my leg and it's increasing, you have to consider other things. You can't just wait and for 2 months for the patient to fulfill the criteria. So I would first consider GBS first. Mild forms of GBS exist. The patient comes to you and then he has like mild foot drop. He had some preceding antecedent infection. You can order some physiotherapy. Up to 50% of GBS patients, they have very mild case. They don't have any complication. So you have to consider that first. And then if the patient progresses slowly, he doesn't, GBS, like it starts about a week, it progresses, and then it reaches its plateau, its maximum up to 4 weeks. And then the patient starts inevitably to improve. If the patient doesn't improve, then you might consider this is a subacute GBS, then see, I mean, the course of the illness. But you have to first consider other causes before saying CIDP. On the presentation of the patient. You can't just go and think of CIDP.
So we have a few questions from our online audiences. And so the first question reads, are there reliable biomarkers for predicting GBS severity and outcomes? And what factors are also contributing to the prolonged paralysis of GBS patients?
No markers that I know of, but some autoantibodies are associated with particular patterns of GBS. I don't know the types off the top of my head. What was that second question?
What are the factors contributing to the prolonged paralysis of GBS patients?
So I would say the disease itself, the severity of the disease. Second is complications. For example, in a GBS, you might have critical illness myopathy, which is a myopathy that happens when you give patients steroid or nerve blocking agents. And these patients, when they stay in the ICU for prolonged periods, they can develop myopathy. So that can be another factor. But I don't really understand the question. If it's a severe GBS, then that's the main reason that the patients have severe weakness. So, I mean, there are additional things that, like I mentioned, critical illness polyneuropathy, which I don't know if we can diagnose in the background of GBS, but critical illness neuropathy, myopathy can be can make it's difficult for us to wean patients off of ventilators.
Okay, thank you. Second question reads, why do some infections trigger GBS while others do not?
Again, it's a bit difficult to answer, but the theory is some patients, they have predilection for triggering autoimmunity. So some antigens in some patients tend to elicit the cascade of reactions, the cell-mediated and the humoral immunity. They activate that, and then the immunity produces antibody against these antigens on the peripheral nervous system. Which patients are predisposed to having this autoimmunity or not? We don't have enough knowledge about that to predict these things, but that's the theory.
Another question on GBS. Is the high mortality of GBS in our setup due to lack of positive pressure ventilation, or are there other reasons?
Absolutely, because one, you need to treat the, we need to have ventilatory support. I've said that two major determinants of mortality are our best chance of decreasing mortality is treating the autoimmunity and providing ventilatory support. So ventilatory support, unfortunately, is not really an option in some setups. But even then, in Blackline, for example, we used to lose patients over dysautonomia, unfortunately. Patients had complications, other complications, septicemia, for example. So there are like disease, particularly disease-dependent mortality factors, but there are other factors like PE, infection, other things we have to prevent. So unless the setup is, the ICU setup is really good in addressing every complication, especially the ventilatory support and the autonomic dysfunction, it's very difficult to lower the mortality of these patients.
Okay, thank you. The next question reads, what is your advice on drug discontinuation after tricyclic antidepressant side effects?
So it depends on the side effect. What I do for my patients before I start them on tricyclic antidepressants is explain exactly what they should expect. And if they tolerate the drug, they tolerate the drug. Usually they just tolerate the side effects. They know about them. They take the drug because it gives them some relief. If they don't, then I don't force my patients to use the drug for 2 months or 3 months. So what I do is I start slow and I titrate up based on their pain and their response. If I want to discontinue, if they have been on the tricyclic antidepressants for a long time, I do it rather slowly because sometimes they lose sleep when we discontinue abruptly, but over a few days we can titrate it down.
Okay, thank you. The other question, can we definitely rely on genetic test for CMT, and how about upper limb symptoms like apraxia?
Apraxia is an entirely different symptom. It's a cortical symptom. It can be caused by stroke, tumors. So apraxia is another entirely different matter. CMT, I haven't. There are CMT. There are like panels we can do for hereditary neuropathies. Since CMT is the most common, yes, we can use them, but daily new loci, new mutations are being discovered. So does it mean that if the test is negative, the patient does not have hereditary neuropathy? No, it doesn't, because we don't rely solely on the genetic test. If the patient has the right clinical context, if the patient has the right electrodiagnostic features, then the negative test doesn't mean he doesn't have the symptom, the disease.
Okay. The last question, any recent updates on neuronal regenerative treatment with stem cells?
No, I don't know. I honestly don't know.
We have a few more questions. How to manage dysautonomia in GBS, and is there any role of magnesium in the management?
So we have to monitor patients. Continuous ECG monitoring and blood pressure monitoring is required. So ECG monitoring, there are different types of ECG abnormalities that we can see: heart block, tachycardia, bradycardia, asystole. So they have to be managed accordingly. There's no blanket treatment for dysautonomia. Magnesium, I have not come across. I don't know. I'm not sure about that.
The remaining questions have been addressed, so thank you.
Thank you, Dr. Solomie, for the wonderful presentation and addressing all the questions present from our audiences. I would like to say thank you for both presenters. We had a wonderful session with both of you. I hope both our in-person and online audiences enjoyed the presentations. And I would like to say thank you, Yetena Weg team, for broadcasting all the sessions successfully without any issue. This will be the end of our session. I would like to remind you that we'll be sending certificates for those audiences who scored more than 50% on online post-CME questions in a week or two, and Ethiopian Society of Internal Medicine will be responsible for that. So you can send us emails if you don't receive your certificates in 2 weeks' time. Thank you so much for blessing us with your attendance, and have a good day and enjoy the rest of the exhibition.